probably back in funds or maybe adult, who knows what it is. So this would be someone who systolically has a blood pressure above 140, diastolically above 90. Again, when you're taking that blood pressure, you want to remember your basics, right? They're seated, it's in their right arm, they have the proper cuff size, legs are uncrossed, they're not talking. I know when we used to do our screenings at Children's for our annual well visit, they'd have the little egg timer, they'd flip it when you sat down, you had to show they sit there, I'm like, oh my gosh, it's 5 minutes, come on already, right? It probably raised my blood pressure sitting there that long. But when we think about hypertension, it is a common cause of pregnancy complication, and it's also the second leading cause of maternal death. So this is why we want to make sure we identify if someone has high blood pressure prior to their pregnancy, right? So when we think about this, we want to make sure they're not using caffeine or tobacco before their readings. We want to make sure that we do it on 2 separate readings, not take one and 5 minutes later retake it and it's still elevated and diagnose them with hypertension, right? That's not how it works. We want to, and only one of those numbers has to be elevated for it to be considered hypertension, okay? When we think about this, if they're trying to get pregnant or they may get pregnant or they are pregnant, we have to think about some of the blood pressure medications if they are taking them, because they can be teratogenic. So for example, hydralazine, if they take hydralazine, right, it should be avoided in the first 2 trimesters and only used in third if the benefits outweigh the risks to the fetus. Things like calcium channel blockers, right, so those can relax, those are used for relaxing uterine contractions and preventing preterm birth. So again, we're thinking about different things. Labetalol is usually pretty safe, minimal effects. Nifedipine, again, minimal fetal effects. So again, just understanding which medications that we can give to the patients while they're pregnant or if they're planning to get pregnant. Now, preeclampsia, or sometimes you guys will see it slang term there, they call it pre-E, right? So this would be considered hypertension, so that elevated blood pressure, after 20 weeks, okay? When we think of this, it's an unknown etiology, meaning they don't know exactly what causes it. When we look at it, there's a video I'll post on it online. It has to do with the dilation of the placental blood flow. The blood vessels are, instead of being nice and straight, they kind of taper a little bit or funnel. So with that is what causes some of these issues. If it's early onset, meaning before 34 weeks gestation, so after 20, remember this is hypertension that starts after 20 weeks, right? If it's before 34 weeks, it's usually more severe than if it started after 34 weeks. So if mom's like maybe 36 weeks and then gets pre-E, it's usually a more favorable outcome to the mom and baby. When we look at this, they used to have proteinuria as a diagnostic criteria, and I understand you'll see at SUMA, they still, and who was it yesterday that had the one with you, right? With this, or was it you? Yeah. So that said severe features. So we'll talk about this in just one second here, but they used to have 2 buckets. They used to have mild preeclampsia and severe preeclampsia. And with mild preeclampsia, they'd have things like protein in the urine, swelling in the body, weight gain over 2 pounds in 1 week when they're not supposed to be gaining that much. So they would look at that as mild, but then sometimes people would say like, oh, I only have a mild case of pre-E, and they would continue on with their lifestyle and not make any changes, and they would advance very quickly because there was no pattern or way that this would go. And when they got to more severe, that's when they would have things like headaches that didn't get better with using Tylenol, laying down, hydrating, things like that. Or vision changes like double vision or blurry vision. They would have right upper quadrant pain, again, from having issues with their liver. And again, it progresses at different rates for different women, so it can be different mom to mom. But we look at things like looking at their lab values as well. And what will this do to mom? So when we think about mom, you can see all the things on the screen here that pre-E can cause. They're also 2 times more likely to develop heart disease later in life. So again, these moms, we want to be identified early and watch and help them. The effects that it can have on the baby, right? So when we think about the baby, these are all the effects that pre-E can do to the baby. So again, we want to make sure that we're definitely checking our fetal movements with these moms. So how do we treat preeclampsia. So it depends on the severity. It also depends on how far along mom is in her pregnancy. Our goal is to control that blood pressure because we don't want, as you would think, pre-eclampsia, we don't want preeclampsia turning into eclampsia, okay, and having that seizure activity and cerebral hemorrhage and things like that. So we're gonna monitor this mom. She's gonna be doing blood pressure checks at home. If mom gets too elevated, we may have to take the baby and deliver the baby, okay? Medications, again, our goal is to keep that blood pressure less than 160/110. I had a student probably about a year and a half ago now. She had pre-E with her twins. She says she came in to deliver, she was like 220/140, like insane, right? Like I couldn't even imagine a blood pressure that high, but yeah, so that was her situation there. When they come in, as you may have seen, I know we had one last night, that was on MAG, but they'll come in and we give them magnesium sulfate. And we give them magnesium sulfate, they get a loading dose and then they get a maintenance dose while they're in there. But we give them the magnesium sulfate to try to reduce the neuro complications. So when we look at this, making sure that we understand too, that magnesium sulfate is a smooth muscle relaxant. So what do you think that could do to them in postpartum? Yeah, so a higher risk of hemorrhage, right? Because if they're on magnesium sulfate, that's a smooth muscle relaxant, and they're still getting it after birth. Because usually the resolution of the preeclampsia is the delivery of the placenta, but sometimes they can take 24 to 48 hours. So they can actually have, they can have seizure-like activity or seizure activity in that postpartum time period. But again, with this smooth muscle relaxant, then the uterus gets boggy and they can have a risk for postpartum hemorrhage. But we also want to look for MAG toxicity because we don't want them having too much, right? So we use the acronym BURP to remember that some of the symptoms that they can get, like bradycardia, muscle weakness, decreased or absent DTRs, hypotension, and so again, looking at that, we want to make sure that we are checking their fundal height and make sure it's firm and midline. All right, so if they get MAG toxicity, we're going to stop the infusion, right? So if someone has toxic levels of anything, right, you should always stop the infusion. Antidote, so again, NCLEX loves antidotes, but the antidote for magnesium sulfate is calcium gluconate. So you should always have it on the floor. It doesn't need to be kept in the patient's room, but they should have some calcium gluconate on the floor should they have some of the symptoms that they have. And again, like I said, that acronym of BURP, so blood pressure decrease, urinary output decrease, respiratory rate decrease, or those absent reflexes. What we don't want to have happen is eclampsia, okay? So again, that's the onset of the seizure activity. It can occur either before, during, or after the mom gives birth. So about a third of it happens after birth, usually within that first 48 hours. So when we think about this, when someone's having a seizure, what's our number one priority? Safety, but what specifically? Airway, right. So again, when we think about that, again, thinking back to our basic safety with seizure activity, rolling them on their side, making sure you have suction available, things like that. Making sure you time the seizure, all of that. HELP, so the acronym HELP, so hemolysis, elevated liver enzymes, or low platelet count. Again, they can have that. 10 to 20% of women that have preeclampsia will develop HELP. Go see Dean Newman at the desk maybe when she's got a HESI, and then come back in. 70% of the time, it can appear at any time. 30% of the time we see this postpartum. So the mom will come in, they'll complain of like right upper quadrant pain, some nausea, vomiting, maybe they have unexplained bruising, some petechiae. So again, that should be signs that you're identifying that this is happening. It's associated, like it shows here, obviously with increased risk of maternal death. So we want to do immediate delivery of the fetus and the placenta. And again, that delivery of that placenta usually allows for a resolution within 48 hours postpartum. It always hides the next slide, so it's in your slide deck, but I've unhid it like 1,000 times, it still hides it. But hyperemesis gravidarum, so HG, you'll hear it sometimes referred to. But hyperemesis gravidarum, with this is beyond just basic morning sickness. This is someone who can't keep any food or fluids down. If any of you are Virgin River watchers, that was one of the characters on Virgin River had HG, but it tends to peak at 9 weeks and usually subside by 20 weeks. Only about up to 5% will need hospitalized for IV fluids. So with these moms, we want to encourage rest as best they can. Small meals, but frequent, right? So if they can't sit down and eat a full breakfast. So maybe they eat just a couple bites and then wait a little bit and eat a couple bites more. We also tell them separate your liquids from your solids, right? So instead of like, they always tell you if you're trying to lose weight, like drink a big glass of water and then eat your lunch, right? Well, we want the opposite of this, right? So we want them to take sips of fluids opposite of their meals so that they're not overwhelming their bellies. And then again, watch for signs of dehydration, watch for signs of metabolic acidosis, things like that. Miscarriage, so when we think of this is again that spontaneous abortion. Once that cervix dilates, we can't save the pregnancy. You can use Cytotec to complete the miscarriage. You can do a DNC where they dilate the cervix and then section and strip the uterine walls. They can have Methergin as well for excessive bleeding. Reduced cervical competence, so this is when the cervix is less than 25 millimeters, and it causes the inability of the cervix to retain that pregnancy. So they'll get painless cervical dilation with the expulsion of the pregnancy if we don't do interventions, right? So these moms, they used to put them on bed rest and activity restriction. They stopped that. It was proved not to be effective. So now they do what's called a cerclage, and I put a picture in the slide here so you can see how they suture around that cervix. So they suture around there, and then again it's placed prior to delivery and then removed about 36 to 37 weeks. It is a risk of infection, obviously, if you're doing this, so we want to watch for fever or any kind of uterine tenderness, and the patient cannot have intercourse when they have the cerclage in place. Ectopic pregnancy, so this is when you get that fertilized ovum planted somewhere outside of the uterus, right? So sometimes you'll hear people call this a tubal pregnancy because 95% of the time it happens in the fallopian tubes. But as the pregnancy grows, as you can imagine, it can cause rupture to happen because it's not going to fit in that little tiny fallopian tube, right? So it can be associated up to 10% of maternal deaths. 50% of the time, they have no identifiable risk factors, right? So it just happens, and there's nothing you could have done to stop it here. Other things like STDs, endometriosis, PID, a previous EP, or if you've had tubal surgery, all increase the risks of having this. So they were given methotrexate to dissolve the pregnancy because if they're stable. If they're not stable, then we're going to do surgery. But our biggest concern or worry with an ectopic pregnancy is that rupture because of the hemorrhage that can happen. Molar pregnancy, so I have a couple of pictures up here on the screen. In the upper right hand corner you can see that's what it looks like. So they call it like a grape-like clusters, right? So it looks like a cluster of grapes. It's a non-viable pregnancy. So as the cells start to divide, they don't divide properly. So again, that's what causes this. But you can see 1 in 1,000 pregnancies, to me that seems kind of, it's frequent. But again, when we look at this, there's no known cause for it. If you were to do an ultrasound on the mom, they call it a snowstorm pattern because it kind of looks like a snowstorm on that ultrasound. So these moms will have a surgical DNC done to remove this non-viable pregnancy. All right, placenta previa. So when we think about this, we're going to talk about placenta previa we're gonna talk about placental abruption. They're two different things, and I'll tell you a couple things to help you try to remember the difference between the two. With placenta previa, the placenta attaches to a lower uterine segment of the uterus. When a mom comes in with placenta previa, they're going to have painless, okay, painless is the key word there, painless vaginal bleeding after 20 weeks, okay? They can lose up to 40% of their blood volume before they start showing signs and symptoms. So again, it's important, this would be considered a medical emergency, right? So again, anyone who has painless vaginal bleeding after 20 weeks, you should automatically assume placenta previa. So with these patients, if they're under 36 weeks, obviously, we want to, and then just send that sign in to okay, good. You want to observe them. If it gets worse, obviously, we can do a C-section. They're at vaginal rest, right? So no vaginal exams, no internal ultrasound wands, nothing like that. So rectal rest too, because again, we don't want anything in that area that could cause a disruption of that and cause more bleeding. So we want to try to limit their activity. Again, worried about hypovolemic shock because of the blood loss here.
I have a question.
Mm-hmm.
Like, is he going to be on stool softeners to limit the rectal?
Yeah, I'm not sure exactly, but that would make sense. I would think, that might help with it, but they're thinking more of like, they don't want anything being inserted into the rectum, so. But with these moms, we're going to, again, use an ultrasound, try to locate that location, because again, like if you look back at this, when I showed you, there's different locations, you can see by the picture there of where this can happen. So they'll try to locate that location of the placenta, and then again, get an H&H, get a type-in screen on this mom, because again, if we needed to give blood products, we want to know. We also want to give the baby some corticosteroids if they're younger, because we want to mature those lungs for delivery. Now, that was placenta previa. Now, when we talk about placental abruption, this is detachment of the placenta from the uterus. So the opposite with this one is painful, and you'll see dark red bleeding. So again, when we think about this, the mom's gonna come in, things like, the most common time that we see this is like blunt trauma. So either motor vehicle accidents or abuse situations, but it can also be things like cocaine use, meth use, things like that. So obviously this mom is also at risk for hemorrhage. So again, we see sometimes newborn stillbirth with this as well. So we want to make sure that we identify this as well. So treatment, if they're less than 34 weeks, and mom and baby are stable, we're just gonna hospitalize them, monitor the baby, give them some medicine to mature their lungs. If at any point they become unstable, or if they're unstable on arrival, we're gonna prepare for delivery. Our biggest concern is to make sure we restore any kind of blood loss. And then we have GIC again. If you think about your cascade, clotting cascade that you learned, so with this, placental abruption is one of the most common causes that moms would get this. But we want to try to look for things like those oozing petechiae, and remove any kind of causative agent, replace any kind of lost blood volume, and monitor the mom. All right, the nurse is in a maternity unit reviewing client records. Which client should the nurse identify as being most at risk for DIC? So prima gravida with abruptoplacenta, prima gravida who delivered a 10-pound baby 3 hours ago, a gravida 2 with dead fetus syndrome, a gravida 4 who delivered 8 hours ago with an estimated blood loss of 500, and a prima who had been diagnosed with gestational hypertension. And select all that apply.
A for sure.
A for sure, yep. Yep, C is definitely. Mm-hmm. One more.
E.
What was that?
E.
E, yes, E. So again, predisposition conditions, so that placental abruption, amniotic fluid embolism, gestational hypertension, HELP, intrauterine fetal death, liver disease, postpartum hemorrhage, all can be risk factors. All right, UTIs, again, 20% of all pregnancies have UTIs. Again, most causative agent is E. coli, just like with adults. But we want to try to treat it because, again, it can lead to preterm labor, low birth weight infants. So again, we're going to screen during their visits. They can have surgery during pregnancy. 1 in 500 women will experience something, things like appendicitis or gallbladder. I had a girlfriend that was in my nursing program. She had a tumor on her kidney, and they removed it during her pregnancy, which to me is just so amazing that they could do all of that. But the babies are okay, they monitor them and move forward. And then of course trauma, so again, leading cause of death among childbearing women. After 4 minutes of resuscitative efforts, if there's still no maternal pulse, they'll perform a C-section to take the baby. All right, fetal assessment during labor. What do we monitor? Again, why do we monitor? Again, we want to make sure that we're looking at the baby's oxygen supply is being maintained, that we want to make sure the baby's not getting too stressed out. We're going to look at those frequencies, strengths, and duration of contractions. We want to make sure that we're looking that the baby's heart rate stays 110 to 160, that we have moderate variability. We want to identify if there's any non-reassuring patterns, again, telling us that that baby could have difficulty and needing to take action to birth the baby. You can use things like a Doppler, or they have this really cool old-fashioned like stethoscope that you can use to listen to the baby, but again, you can perform those. But the most common that we see, like we talked about in lab, is the internal or external fetal monitoring. So externally, I know for those of you in L&D, I'm sure you've seen it. You see your picture here, where we got our TOCO and our transducer there, so that we can see the fetal heart rate as well as the contractions. That would be the external version. We also have the internal version. Again, we talked about those in lab. We're looking at a baseline heart rate of 110 to 160. If it's absent or minimal variability, it could mean fetal hypoxia, it could be a neurological injury, it could be that the baby's been exposed to some kind of CNS depressant like narcotics or barbiturates or even anesthesia. So we want them to be moderate. Moderate means good. And again, we don't want marked or sinusodal either. So again, here's a picture of a minimal, again, less than 5, so again, or we don't want that, and then also absent, so we don't want that either. But what we do want is moderate, so again, you can see an example here of a moderate amplitude, and then the marked and the sinusodal. Babies can also become tachycardic, so again, thinking about anything over 160, but it has to be sustained, so greater than 10 minutes. If that happens, we're going to do some interventions with the mom. So again, looking at the heart rate, bradycardic, again, less than 110, but again, sustained. So things like tachycardia could lead to late deceleration. So again, when we think about that, we want to put them sideline, give them some oxygen, IV fluids, notify the provider, things like that. Bradycardia can be caused by things like fetal cardiac problems, viral infections, hypoglycemia in the mom. And then we also want to be cautious in our tachycardic babies for maternal fever. So again, thinking about prolonged rupture of membranes, that's a great, the amniotic fluid is a great growth for bacteria. So looking at that, giving them, making sure if they have a fever, we give an antipyretic, oxygen, and a fluid bolus. So this is an example of fetal tachycardia. Again, you can see this baby's heart rate's about 170, so that would be fetal tachycardia. And then we have fetal bradycardia. So again, looking at this picture here, you can see the baby's heart rate's about 100 here. All right, so again, when we look at those accelerations, just like I mentioned in the last lecture, that you want to have increases in fetal heart rate, 15 beats for 15 seconds, again, returning to baseline. This is reassuring, there's no intervention needed, this is just a healthy fetal placental exchange, right? If they have early decelerations, again, it's good to be early, right? We talked about that's contractions, squeezing of the head, so no intervention needed. If they have late decelerations, that's placental insufficiency. So whether it's hypotension or preeclampsia, so that mom, we're gonna put her sideline, give her IV fluids, give her oxygen, again, notify the provider and possibly prepare for birth. So again, here's some pictures of accelerations here. Again, that early deceleration, remember with the early deceleration, the drop in the heart rate mirrors the peak of the contraction. So again, those match up. It's good to be early. Again, they will return back to baseline at the end of the contraction. It's a normal finding here. Here we see a variable deceleration. If you remember from your veal chop, V and C is variable, stands for cord compression. So this is compression of the cord. You can reposition, put them in knee to chest position, give them some oxygen, again, watching them in this time period. And then of course late. So again, as we talked about in lab, the peak of the contraction, the drop in the heart rate is after the peak of the contraction. So that's late. It's bad to be late. You don't want late decelerations. So again, looking at that, we want to make sure we perform our interventions. If someone has a prolonged deceleration, again, we want that return back to baseline, but you can see in this picture that VD's deceleration has dropped and it's stayed there for a long period of time. That causes, obviously, as you can imagine, an interruption, right, to that fetal oxygen supply. So again, we want to make sure that if this continues on, we may have to take the baby. All right, the next one I talked to you about pain management, but like I say, I'm not an anesthesiologist, so I give you the basics of what you'll need to know as far as OB and care for patients and what nurses can do and what you'll be asked on the NCLEX. But pain, of course, let me see what time it is. You know what, let's take a break now. So go ahead, take your break.